Well, it's been probably over 2 years, Anish, since you came on Healthcare Unfiltered. I really appreciate you coming back on this episode because we're not going to talk about cardiology. I think the last time I had you on the podcast, we talked about, I think we were talking about myocarditis, the day where COVID vaccine was still early. We talked about some cardio oncology stuff, and I had also Vink Murthy on that episode. And in fact, you won't remember this, but I would. It was the inaugural episode of Healthcare Unfiltered when I rebranded it from Outspoken
Mm.
Oncology. So, welcome to the show, my friend.
Thank you for having me. Thanks for taking the time.
And, having a cardiologist, I'm not talking about cardiology, is interesting, but I've invited you on the show because I honestly was very much intrigued by a tweet that you put in weeks ago and was very, very focused on healthcare policy. So before we delve into this, I want to make sure that listeners and viewers know who you are. So let's do a quick intro.
Yeah, no, thanks, Teddy, again for having me on. I'm very impressed by what you've done in the last many years. It's really incredible to see how much time and effort you put into this and producing a high quality product. I know it's
Thank you.
incredibly hard to do, and I think you're one of the few that do it and do it well on a consistent basis. So
Appreciate it.
so Congrats to that. I'm a cardiologist, and I'm just a private practice cardiologist. Practice in Philadelphia. I had no particular interest in healthcare policy. I thought cardiology was hard enough, which it is. It is hard enough. And then the problem for me was is that I decided to start my own practice, and once you start your own practice, it becomes almost impossible to avoid healthcare policy. So ideologically, I come from the left. I believed I have I have most of my family members are from the left. My uncle is a reasonably prominent economist who's extremely left leaning. As an 8-year-old, I wrote letters to Indira Gandhi, the Prime Minister of India at the time, talking about the black economy and how terrible the black economy was. And so I'm ideologically actually I come from the left, and I've voted in that way when I got here because the idea I had when I first came out and started practicing was that I have there are people that are uninsured, right? And to me, it was crazy. We live in the richest country in the world. How is it that people are uninsured? And from a practical standpoint, there's 15 to 20% of patients that are on my list in the hospital that have no insurance. I still see them because obviously you can't not see them because they don't have insurance. You have a moral prerogative to see them. And it seemed a somewhat simple solution, which the left which is what the left, the political left provides, which is to say, look, we'll mandate insurance in some way or the other, and collectively get these folks covered. And so, it seems to make business sense, and of course, more importantly than the business side, it seems to cover the moral prerogative that we have as a society to cover everyone. And so yeah, so that's what the Affordable Care Act did. I was gung ho. I was like,
So what
hey,
was the Affordable Care Act was the tipping point that made you interested in just healthcare policy in general as a
yeah,
field, or did you feel like you had to learn about it because you were seeing patients that were
yeah.
insured by the ACA?
I mean, healthcare policy. I knew nothing about. All I knew was is that I had a bunch of patients on my list that were uninsured. I felt terrible for the patients, and as a practical matter, it's like, well, okay, you just write off these patients, right? And it's like, so then it's like, you're, obviously you as physicians, as providers, as the hospital, etc., are covering these costs. Those costs are being shifted over to, and that was my very simple understanding at the time. So it seemed a relatively simple thing when someone, the Democrat Party proposed the Affordable Care Act as being a, some type of mandatory insurance plan that everyone had to pay into to cover that, folks. I was like, great, people will have insurance for these terrible things that happen that put them into hospitals. And for small small business owners, okay, you're now not writing off 15-20% of your business because they're not covered. So that was it. That's all I understood. I didn't even spend any time thinking about healthcare policy beyond that. It just seemed like a very reasonable thing to extend coverage in some fashion and do it that way. And that's it. I knew nothing. I didn't read anything about the ACA. I didn't read the ACA bill. Nothing. I just knew that there was some plan to cover these folks.
Were you at the time when the ACA was enacted into law, were you already in your community practice? Did you already
Yeah,
start your practice?
yeah,
Yeah.
yeah.
Okay.
No, I was in, and I was very happy that it was passed. And then 2-3 years in, again, you have to practice. You're running a private practice, right? It's there's no quality improvement plan. There's no quality improvement department or anything like that. So now I was like, okay, great. These folks have insurance now. This should be, this is fine. But then you started getting all these different. What I started having to deal with was all these different stipulations related to the ACA, right? And early on, it was like, okay, fine. It's some silly thing you have to do. You have to print a summary report and give it to the patients. And the way it's staged, the way it's set up in the ACA kind of was that it's initially set up as like, if you do these simple things, you will get an incentive. There's a bonus payment or something like that you get, right? But then as the years passed, the things they had to do got progressively more and more onerous. And if you didn't do those things, now all of a sudden you had a penalty to pay. And it wasn't just a penalty on just those 9% of patients that were uninsured, right? Because that's 40 million people or so were uninsured, or I forget what exactly it was, but it wasn't just covering that. Now the ACA now covered everything. The ACA, as part of the passage of the ACA, it covered all of Medicare. So it was transitioning the whole healthcare system into this value-based system, which was not just focused on administering care to patients, but was focused on making sure you were giving the right type of value to patients, right? Again, and it sounds great to me. It sounds great to anyone who's listening, right? The problem is in how exactly you go about implementing it. And it became very clear very quickly, 1 or 2 years in, that the ACA was just a complete disaster in terms of, and that had nothing to do with value. And it was just basically, and so the ACA very quickly, I came to understand it as I think it should be understood, as a pretty massive giveaway to some big players in the healthcare space.
So
Insurance companies.
we're gonna go over that to the ACA, but
Yeah,
I just wanna pivot though to one thing is
yeah,
that your knowledge about healthcare policy may have started obviously
right.
because of that, but the reality is even the stuff that we're gonna talk about today that intrigued me when you
Yeah,
tweeted them
yeah,
were beyond just the ACA. I mean,
yeah, yeah, right.
you talk about 340B, you talk about
Yeah, right.
pre-auth, which is really, to me, is a lot of things, but it all started with the ACA, like you
Yeah,
said. And you mentioned it took like 3-4 years. You say it's a complete disaster. I mean, some may argue that's a bit of an exaggeration because, I mean, like,
right.
convince people why you think it was
Yeah, yeah.
quote
So
unquote disaster.
right, the ACA definitely what the ACA did was good for patients that were unable to get insurance in the marketplace as it existed. All right. So there's no question that there's a portion of patients that could not get insured because they had significant illnesses, because they were they were in this gap, right? If you fall below an income gap, you get covered by Medicaid. If you're over 65, you get covered by Medicare. But then there's this group of folks that aren't able to get health insurance through their employer, and are left on their own to try to get health insurance. And certainly, depending on where they fall on the income scale, even if they're above the the poverty line, what Medicaid defines, you can't get it. So there's no question for that group of people, the ACA was a boon. So yeah, I should be careful. I don't mean to say that we don't as a society have some type of moral obligation to those people to cover those people. But to do it this way is just to, I say it's a disaster because in order to cover this sliver of people, right? And again, you're talking about 40 million total that were uninsured. The vast majority of them just didn't want to pay for insurance because they're young, healthy, etc., right? And they don't see the value in having healthcare, right? They would rather just not, I mean, many people do not People don't think it for many different
But
reasons.
but
But
should
there's
should
this
we
tiny
should we
sliver of
but
them.
should but should we let somebody who is that young, right? Should we just, theoretically, somebody who is
Yeah,
young and healthy and all of that, they usually are forced to buy some form of car insurance, some form.
yeah,
They may not have the full
yeah,
coverage, but they have to buy
yeah,
something.
yeah,
Should we let somebody who is young and healthy go without
yeah,
health insurance because if they get sick and get in a motorcycle accident, get in the hospital,
yeah.
then like
No,
as
no,
well,
I'm right. So I was on board, which is why
yeah,
theoretically this sounds great, and this is what I mean, and this is where I was in terms of
right.
I voted for the ACA twice. I voted for for Obama twice because I was like, yeah, and this was of course a part of it because it seems to make sense. The issue is, Shadi, is that as I've learned in the decade or so since, is that any legislation that's passed as good as it's intended, tends to get corrupted by a variety of different folks that are that are sitting and legislate that are part of that legislation sausage. Okay, and that's what happens. So absolutely, it makes a tremendous amount of sense. Take the 40 million people, right? Mandate some level of insurance, just like they're mandated to have, car insurance, right? And then just and cover everyone, right? And pool that risk and stuff, right? But of course, the legislation will not, the folks that are sitting at the table making these rules, once they see this, once they see that they can mandate money to be collected from 40 million people, suddenly their eyes get big and they're like, aha, there's something that we can get out of this, right? And that's where the problem starts. So the problem is not that I don't, and again, this is where you get down this very, very deep rabbit hole where you end up where I end up now, right? Where I end up now is that no, we should not mandate anyone to get insurance. Well, we'll explain that as we comes maybe through the
Mhm.
podcast. But the problem is you just cannot these legislations. As simple as you'd like to make them have, as you would like to have them, the moment you have these type of things going through the legislative sausage factory of Washington D.C., they get massively corrupted. So what ends up happening to the ACA is that it ends up becoming largely a giveaway, a taxpayer subsidized giveaway to large health insurance companies and to large health systems, right? And what does that do? That makes healthcare more expensive, right? And ultimately less accessible, not just to those 40 million people that needed it, but to everyone, right? Because it's creating this massive boondoggle. So yeah, so I think the ACA was it was a pretty much a huge net negative for that reason. So I think there are better solutions to cover that tiny sliver of the people. But this is what happens in healthcare all the time, right? Even when you have a simple thing in a city, in a local city, take Pittsburgh, right? Or take any other small town, right? You have one big healthcare system that's there, right? And you have a couple of insurance companies that are negotiating. The moment that there's a negotiation that's taking place, the health systems are screaming, are getting on the phone to journalists and saying, hey, this large insurance company is threatening to drop us. This is going to be a huge problem, and so and so and so the kids' health is going to be impacted. I cannot believe United Health, or I cannot believe IBC would do that, right? And so there's this article that's published by some well-meaning journalist saying, this Medicaid plan is considering dropping CHOP in Philadelphia, and oh my God, this is going to be a disaster. And you have all these nice hospital quotes saying, yeah, this is crazy. All we want is our reasonable rates, and here this insurance company is doing this. So there's just what I've tried to do. I said I tried to write a lot early on in 2014, 2015, 2016 to try to get physicians and the consumers of healthcare, which is us, by the way, too, kind of more cognizant of these games that are being played, because the better educated we are to what's going on, the better we can discuss in a more intelligent way and see through some of the smoke screen that's constantly thrown up at us.
What's the counter argument that you hear from colleagues or friends or folks who obviously that may not agree with you about the your criticism of the ACA. What have you heard? Because there's countless arguments in favor of it, and there
Yeah, I
are
don't want to
some
make this.
paper.
Yeah,
No, but
yeah.
like, what's like,
Right.
top two, for example, where people say, well, okay, I hear your point, but what do you hear?
Well, again, I think the biggest thing you hear is that look, there was a problem that you had to solve, and the ACA solved that problem. And in the sense that there were high risk people that weren't able to get covered on the market in the insurance market, and the ACA solved that problem, right? So that is, and I don't have any
So it's
I
like
don't
a
have
face value, without
yeah.
in-depth discussion.
Yeah, so I mean, and that's true. That's absolutely true. The question, the more nuanced response to that is, it's not, I don't think anyone. I think the vast majority of people in the United States, whether they be right or left, they want a plan for the 50-year-old who is making $45,000 a year, and cannot get health insurance through his employer, and then get some horrendous thing that happens to them. They end up in the hospital. They suddenly have this large bill, and now the hospital is going after them. So look, I think everyone, even Milton Friedman, by the way, Milton Friedman is the economist who is regarded as a big proponent of the free market and whatnot. Everyone is interested in trying to provide for those folks. But it's very important that one creates one doesn't just blind themselves to the process of doing that. Because if you don't hew to certain principles, I think you end up with what happened in the ACA. You end up with, if you're ignorant to understanding some basic principles of what may happen if you don't understand, then you have what happens with the ACA. You have this
Do you feel,
fantastic.
do you feel that physicians who are in large academic institutions or employed by the hospital are not, they don't understand what you're saying because they're not really running their own practice. They seem to be shielded a little bit. They're salaried by the university or by the hospital, or is the impact of the ACA as you're describing it somehow trickling down to even employed physician by healthcare systems and academic physicians?
No, I mean all of the above. I think employed physicians are shielded. They get a salary, and they don't quite have an understanding at all of what it takes, how the sausage is being made at all. And on top of that, I think the vast majority of academic physicians have unfortunately, when it comes to healthcare policy and many things, have these political blinders on. And I think so I think it becomes very politically tribal. The moment you say you're against the ACA, it's like, oh, you must be some crazy right winger, and they don't even listen to they stop listening to the arguments. And that's something I learned the hard way. I just thought you could go up and make these arguments and discuss that, hey, this is why this doesn't work from the standpoint of somebody who's delivering healthcare and has to go through all these different rules, and can see through the fact that accountable care organizations we're always going to fail. That Medicare Advantage, Medicare Advantage, by the way, is not part of the ACA. That's why I'm not just
Right,
restricting this to
right,
the
right,
ACA. Just the
right.
ACA, you asked, why did I begin to go down
Think
this
of
rabbit hole
policy,
of
yeah.
trying to understand? It
But
was the ACA, but the whole system
yeah.
is
But
not
do
set
you,
up
do
in
you
a.
feel you said that there may be a way, like, okay, so as an oncologist, I'm
Yeah.
very fully aware that sometimes there's limitation to what you could do. And sometimes you just have to say, you know what, unfortunately, this is what it is. I'm just going to have to live with this unfortunate situation.
Right.
What you're suggesting is that there may be another way, not the ACA, to insure these 40 million people who are uninsured. And I actually don't know if that's possible. Maybe we just have to live with the fact. I mean, unfortunately, unless you have like a socialized medicine all over the country, do you think there's an actual way, not the ACA, to make sure that healthcare insurance is accessible to everyone? Because I may argue that I'm not sure that's doable.
Yeah, no, yes, that's a great point. So I think it's important when in thinking about this, and by the way, I'm not like this is not something that I'm an original in coming up with this. When you're talking about healthcare policy, or actually even anything, whether it be oil, I don't know, oil or commodities or whatnot, right? There is the North Star. There is this perfect system, right?
Right.
And then there's what is like what exists now and what's politically feasible. All right, and I think you have to be able to keep both in mind. All right, and so you know, do I think that do I think that there could exist a system that's significantly better than what we have right now, that lowers the cost of care, that lowers the cost of healthcare, and makes healthcare much more accessible to more people? Yeah, absolutely. And but the question then becomes, well, you have this current system right now, and it may not be politically feasible to get to go from zero to 60. So then the question is, okay, what are the transition points in between that kind of lead us to this point? But it's still important to what is our goal? The goal is, can you make healthcare more accessible to as many people as possible? On top of that, can you then create a system for these horrendous things that may happen to people that come and happen out of the blue? And here's the thing, I don't think, we're so used to the world is being as it is, that someone has to provide these things for us. Yet, if you look across at other other areas of the economy, right? You don't have, the government is not saying, the government has no program to make sure everyone wears shoes. The government has no, even when you look at even when you look at auto insurance, right? You have some rules and regulations that say you have to have some minimum amount of insurance, right? So, which covers a certain suite of things, okay? But then there's a bunch of different things that aren't deemed, part of that, right? So if you want your oil changed, you pay out of pocket for that, right?
I think I think the problem
and
is,
so yeah,
go ahead.
and I understand what people say, and this is the argument that was made by Ken Arrow, the famous economist.
Mhm.
And Ken Arrow, famous paper, argues that, look, healthcare is different. Healthcare cannot be treated the same
Right.
as car insurance, right? But again, I think Ken Arrow was wrong. I think history has the history of what's happened since, has proved that. I think what has happened, principally speaking, right, is that we have subsidized healthcare to a massive degree. We have trusted the physician community to a massive degree to decide what is and is not deemed essential, right? And Ken Arrow's arguments, right? The Ken Arrow, the economist, who said, look, healthcare is separate. It does not function as a real market. Therefore, the government, you need a significant amount of help here. Government needs to provide, and there needs to be a significant amount of intervention to make this work, right? And that's government's job and role, right? But what Ken Arrow, rested a lot of his arguments on were the fact that the physician community was this completely or mostly highly ethical group of folks that did things out of patient interest, not things out of physician interest or healthcare system interest and whatnot. And unfortunately, that's where Ken Arrow's argument has clearly broken down, right? I mean,
But part of the reason, so I'm in the middle. I think Ken Arrow may not have been completely correct, but I don't think he was completely wrong, because the issue when it comes to healthcare is really cost. And I think we're going to talk about this, because I'd like to segue from this to pre-authorization, which you commented on before.
yeah.
But it's really cost. The reality is, Anish, I understand there are two arguments, and I'd like you to react to it.
Yeah.
Number one is, yes, the government doesn't regulate restaurants or, buying shoes program, but you could buy shoes for $30 and you could buy shoes for $500. You could eat a steak or you could get a sandwich from Subway. But unfortunately, when you have diabetes, you need insulin, or when you have a relapsed lymphoma, you need autologous transplant. there's no substitute. You either get this or you die. You're not going to die if you don't wear fancy shoes. So I think the problem, the argument, and I don't know what the solution is, but the issue with healthcare is that it has gotten so expensive in the US, where if I know I could go to see you, for example, and you charge me, let's say, whatever, $150 a pocket, and you do an echo for me for $200, I'll go and see you and pay out of pocket. It's like anything, like going to a restaurant. The problem is I'm going to get a bill for the echo, I don't know, maybe $2,000. I don't know what it is. I'm just throwing numbers. Like if I do a PET scan, CAT scan. So I don't know how to reconcile this, because I understand the free, I believe in free market completely. The problem with healthcare is that it is like almost life and death for a lot of things. Not
Yeah.
everything, not
Right.
everything.
Right.
I don't need to have cosmetic surgery for my nose, but
Yeah. Yeah. No, so the solution would be that, the market would, there's such a demand, Chadi, for, look, so you got to first understand, of course, that the vast majority of healthcare costs, which all smart people do in healthcare, the vast majority of healthcare costs is produced by the minority of folks, right? Which is similar to fire insurance, right? Or whatever insurance you do. I mean, that's what insurance is there for. You buy insurance. Like, you are not running around with a house that's not insured against a fire, correct?
Right.
So, so again, these singular events that individual community members cannot cover, right? Those, there would be a demand for insurance that would come about, right? The government does not run around providing a fire insurance program or hazard insurance or whatever insurance, right? There's a need, because people like you, me, etc., whatever, we want to be insured. We want insurance against those big time things that we aren't going to be able to handle, and that's perfect for the insurance market to cover on its own, right? So those 10% of people that need a heart transplant, that have some lymphoma that there's only one treatment for, right? Those are the perfect setup for insurance. Okay, that everyone would buy those insurance. There'd be tons of insurance companies that'd be running around trying to sell that, and that. So you have to separate that out, which clearly there would be an insurance market for, whether the government existed or not. Okay, from a large majority of healthcare that is not delivered in those particular circumstances. And the issue, Chadi, is that part of the healthcare market, okay, has gotten massively expensive exactly because we have subsidized it, all right? And we've subsidized it to a massive degree all the way from the 1940s, right? So the original sin is, employers providing health insurance because, the government, as part of World War II, introduced wage controls, right? You couldn't increase wages. Companies needed to attract people somehow, and so they introduced healthcare
Yeah, no,
benefits.
I know the history, but what I disagree with, hold on.
Yeah.
The history, yes.
Yeah, so no, so if you separate it out and say, okay, look, just like car insurance, right? Okay, I mean, if you have if you have some XYZ problems, there's so many things in the car insurance thing that you just cover, you have to cover out of pocket. It's the same type of thing. I think it is certainly possible to create a system where, where certain things are covered and the rest is not. And it's hard to think about this because you're talking about the cost, right? Why has the cost of healthcare gone up so much? Milton Friedman, the man himself, right? He had two bypass surgeries separately, 20 years apart, right? One in 1972. It was at Mayo, all right? He says, again, according to his words, right, in an interview that he gave, that the bill that he got, again, I have a hard time believing this to be true, but he's a smart guy and he's saying it. So in an interview, so he's saying the bill that he got for that surgery at Mayo, okay, in 1972, and this is when he was before he was 65, so it wasn't Medicare, I don't think, was $4,000. Okay, he then got operated again in 1992, right? The bill is considerably higher, okay. And then he gets, and you can imagine now if you go in for a bypass surgery, what that bill is. And here's the thing, right? You can talk to surgeons. Fundamentally, has heart bypass surgery changed fundamentally?
But the reason I think it has,
1972 now?
but the reason I think it has gone up, that's where maybe we disagree.
Yeah,
I think the reason it has gone up because the market has allowed it to go up. Because in other words, if I know that you are willing to pay me for my house,
Right.
$100, and
Right.
I charge you 50, then I'm not being smart. So basically, the market has allowed that bypass surgery you charge 4,000. Okay, the market tolerated that. Suddenly charge 10,000, the market still tolerate this. And with time, whether it's the hospital, whether it is the surgeon, whether it's the cardiologist, they kept stretching, stretching, stretching. And as long as they're getting paid, they realize they can stretch it further. There's a reason why cancer drugs, as an example, just from my own playbook, they're expensive. The reality is, we already know that many of the
Right.
cancer therapeutics are not being priced based on the R&D. They're being priced based
Right.
on what the market tolerates,
Yeah,
right?
yeah,
That's what it is.
but it's not a market in the sense that it's a market of third-party payers, right? So it's not Chadi
Yes, yes, I
negotiation. It's
agree.
like these
Yeah,
third-party payers negotiating. So
right,
yeah, no, no, no. So what Friedman would say, and I think Friedman has been borne out to be correct in this, is that the massive inflation in healthcare costs is because you have third parties that are running around paying for this. The point is that shoes have not gone up as much.
right,
Anything that you have
right,
not subsidized has not gone up as much. So yes, costs would go up over time because, and there's of course other parts of the economy are growing and getting more expensive. So I'm not saying that today I would not expect a bypass surgery to cost $4,000, but this massive, ten thousand
right.
percent rise, that is almost definitely because you have third parties that are paying, and so there's no competitive price pressure that anyone is applying to these people. You just end up paying more and more and more out of your premiums. And it's not even you, right? It's the employers
Right.
who are paying for healthcare premium or paying these healthcare costs. And oh, by the way, there's a tax break that everyone is getting for that. So,
So
I think,
payers have argued that
yeah,
implementing pre-authorization process and
right.
system is something to kind of contain cost a little bit to make sure that the bad behavior of ordering tests or therapies
Right.
are in place. What are your thoughts on that?
No, and I think given the system that we currently have, look, and by the way, there's two arguments. You argue from the vantage point of a physician. You argue from a vantage point as a tax-paying physician that wants what's best for society, right? Those are the two things that physicians also need to keep in mind when they're talking about this. As a physician, hey, look, yes, absolutely, I want all prior auths to go away. I want whatever test I order, I want I want it to be covered because again, I'm the guy that has to put and make payroll every 2 weeks, and part of that payroll is is half an FTE or whatever it is, full-time equivalent, half a FTE or whatever, that just involves somebody who's doing prior auth. Okay, it's a massive drain on practices to do that, right? And a lot, and some of them are crazy, right? Like some of the Medicaid insurance plans, I think their general practice for a first time, if you order a CT, is a denial. That's just what they do, you
Yeah,
know? So
because
look,
they assume if you're not going to challenge that, they
right.
save money.
Yeah, I mean, and yeah, the more they tie you up, so look, I am totally, and there's certain private, commercial insurance plans that are well known to do this in a bad way. And things that are very standard, basic, they'll just tie you up because they know that the more they tie you up, the more money it is that they make. So look, I completely understand and I get it. And but part of the major issue is that again, when you're looking at this problem that we have, you have to think about it from the vantage point, of course, of payers. And the vantage point of payers is also the vantage point of our patients that are paying premiums for
Mhm.
healthcare, right? Increasingly, more and more of their salary is getting sucked into that, right? So from the vantage point of not just a physician who's running a practice, I would love to have no prior auth at all, right? But from that other vantage point that we still have to keep in mind if we're talking about policy, right? We have to understand that, like, there is somewhat of a responsibility that insurance companies have, a fiduciary responsibility that they have to their clients, who are our patients, right? So that their premiums don't keep getting jacked up, and so, and
No, I
we
think I think
know
insurance companies' fiduciary responsibility is to their
they're
shareholders.
shareholders. Yes, yes, absolutely, absolutely. But again, You're absolutely correct about that. I misspoke, but they're not going to stay in business very long if
No,
they don't
I know what you're
order.
saying.
And look, and I totally understand. I get it. You know, the physicians out there who are throwing things who will throw things at the screen now is that yes, you know, United Healthcare has ridiculous, you know, profits and blah blah blah. I understand, but the issue is that we cannot divorce ourselves from the reality that that there are many colleagues of mine, many colleagues of yours that you know want therapeutics that on this, you know, non-actual market, this weird third-party market that exists, want things that are incredibly expensive, okay? And it is us saying that, hey, this must be done, this has to be done.
Yeah.
And if we just, you know, so there's somebody that, you and I saw a discussion about some patient that who had metastatic cancer and organ transplant being covered for that, right? I mean, you know, again, I don't know the particular
So
stuff,
two
but
issues about
yeah,
the pre-auth. You commented about the pre-auth. I wanted to tell me, do
yeah,
you ever think that the pre-auth, because you know, I mean, we all hate it.
yeah,
I can see the advantage point from the payer perspective because they see some of these practices and they
yeah.
say, well, wait a minute, we have to do it. But the most part, I think we can agree, maybe over 90% of physicians are trying their best to do are trying their hardest to do their best. So tell me about the pre-auth. That's number one. And number
Now,
two, I wanted to comment as you allude to this. You've been on and off. I've seen you somewhat critical of Mark Cuban and cost of drugs and what he's trying to do. And you know, some of the cancer drugs I've
right.
seen, the prices that he's offering, I have to say, I mean, I'd like it's amazing because, you know, like when Gleevec is a couple $100 versus thousands of dollars, how can you argue against that?
Yeah, no, right. So I'll take the first,
The pre-auth.
yeah, the first look, prior auths, you know, the issue is that you have to create this is, and this is what I mean. This is what I mean when I was discussing this, right? I see physicians too often that are reflexively reaching for first order solutions, right? And you can't do that. You have to work, and we have to work towards creating a system that incentivizes people in a proper way. So at the moment, what's happening? You made that comment about 90% of our colleagues are trying to do the best for their patient. Look, but the issue is, and again, talk to Vinay, right? Vinay, you know, Vinay will say, okay, I'm sure most of my colleagues think that, you know, this new cancer drug is the best thing for this patient, right? And again, I think Vinay's practice pattern would be very different than that person's practice pattern, right? And you know, Vinay is of the opinion that there's a lot of stuff that's happening in the world of oncology that, you know, perhaps is kind of, you know, very low yield but very costly, correct?
Well,
I think
I don't agree with the views on oncology. I
right.
think
But the point,
I think that's point of contention
right.
in terms of
But the point
oncology.
is that's fine. That's the point of contention to what that number is. But the point is that there's nothing that limits physicians in terms of choosing anything it is that they want, right? In the world of cardiology, right? I mean, John Mandrola, who you know is you know, we both know well, writes a lot about the fact that there's a vast array of things that are being done. And again, all those physicians think they're doing the best thing for the patient by recommending this device, that device, blah blah blah. But again, if they are unmoored from the cost from the cost aspect of it, and they have incentives to put device X in a person, right? Or oncologists have an incentive to prescribe a drug for whatever. It's very hard to remove yourself and act like we are unbiased entities. And we have no one to kind of push back against us. Like, who's going to push back against us if you take away, in the current system, if you take away payers coming back to us and saying, hey, you know, this why do you think this is reasonable? We think
So this is in favor of prior auth. What you're arguing, that's why we should have prior auth.
I'm saying in the current system,
Right.
I'm not sure.
Okay. No, I
I'm
hear
not
you.
sure there's any other. I mean, I would love to hear from you. I mean, who else is going to
Well, I mean,
position that?
I think my issue with prior auth
Yeah,
is what you mentioned actually earlier. You said there are sometimes always the immediate denial, no matter what you're ordering.
yeah,
And there are certain things that we order that are completely standard of care. Like, you know, it is standard of care to order a PET scan to stage a patient with Hodgkin lymphoma. And you see that sometimes denied. And when you actually get on the phone and you tell them, look, this is like part of the guidelines. I can't stage this patient without it. And eventually they agree. But in my view, I believe they deny it because if you don't call, they save money. That's number one. Number two, with prior auth, oftentimes you're not talking to a peer. Imagine you're trying to call me and to convince me that you need to get a TEE on a patient, and I'm an oncologist, and all I know TEE is it's what it is. But I can't, like, I have to go to a grid and like these arrows and all of these things to see if it meets these things. I think there's a lot of these issues that you're not talking to a peer who really knows the nuances. And the reality is a lot of these things are nuanced. I mean, it's really clinical judgment, all of these things. So I know that you are not a fan of prior auth. At the same time, I know that prior auth is important to prevent inappropriate behavior for some physicians that probably go overboard. So I don't know where we strike that balance.
Right. So we need a different system, Shadi. I don't think this current system works. I don't think the current system works to.
What is that? What is that new system that you would suggest? Or is it you don't know what it is?
No, well, I think again, there's the North Star, then there's what's politically feasible, right? The North Star is that there's no there's we get out we take third parties out of the game of covering things, and that's the North Star. I'm not saying that that's a politically feasible thing to do now. We've gone the other way, right? We have Medicare Part D and government is so.
But what do you mean
We
you
have
take
to
the
get out.
third party? What do you mean you take the third party from
So,
covering things?
right. So you have to allow the market to come up with solutions to getting these drugs in the hands of customers. And so this would again take the form of an insurance market that arise, right? The insurance market a private insurance market would arise because there's a need for it, there'd be a demand for it to cover drugs, say, that are super expensive, or to cover imaging tests that are expensive. But the vast majority of things, would be deemed things that you just have to go out and get on your own. Let me give you an example. Calcium scans, right? Calcium scans are not covered. They're CAT scans, low-dose CAT scans of the chest. They're not covered by insurance companies. These are low-dose CAT scans of the chest that are done for primary prevention. Silicon Valley thinks that every person in the United States needs to get it. And because it is not covered by an insurance company, because they have to get a patient to fork out money for it, right? The average cost of one of those of a low-dose CAT scan of the chest is something from $60 to $85. Okay, if you look at and that's this low-dose CAT scan chest that takes a second to do.
I see what you're saying.
Even if you look at CT scans, look at MRIs, and if you go and look at the cash prices that you can get these for, they're vastly different than the prices that happen on the insurance side. So there's no question that as soon as you have a third party payer, okay, where the patient is just like, here's my card, I want this thing, right? The insurance companies are not don't care about the money as much as you do, okay? So I'm not going to pay $2,000 for an MRI out of pocket because that seems absurd. My insurance company will pay $2,000 for an MRI. All right. So if you removed, right, and again, this is North Star stuff.
So why would the insurance pay it?
Well, the insurance companies are.
Why can't the insurance company say no? You don't need the MRI.
Right. So that's the problem here. See, so that's why we're talking in like room. We're talking on one level in terms of, well, why are they denying? The reason the insurance companies are running around trying to deny MRIs, Chadi, is because the freaking person who's providing the MRI in your local hospital is running around trying to charge like $2,500 for it, and that's why the insurance company is flipping out and saying, "Oh my God, I can't do this," right? And again, why is this happening? You have healthcare consolidation, blah blah blah. You only have 3 hospitals in the area. The oncologists that are providing, you don't have enough outpatient imaging centers that can do it. So we have a screwed up market that is making us have these weird, silly, round and round discussions, right? And the whole reason that the insurance companies care so much about denying things, okay, is not, yes, there's bad incentives, perverse incentives, and blah blah blah. But if I guarantee you, if the MRI cost $400, the insurance company will not run around trying to deny it, right? I got approached by a nurse practitioner at a practice that I spent some time at, and she called me and said, my daughter is 3 years old. The pediatrician heard a murmur. They wrote me a script for an echo. they go to get an echo. This is that shop in Philadelphia. There's only two main children's hospitals, and the cost. They told me the cost was going to be $5,000 for the echo. I was like, okay, I mean that's crazy, but the insurance company, what, don't you have insurance? She's like, yes, I have insurance, but I have a high deductible healthcare. I have a high deductible plan, and I'm going to have to pay $3,000 for an echo, right? This shows you the power. So this is why you have this crazy thing happening. So what would Milton Friedman say in terms of how do you make a graded approach towards getting to the final North Star of saying that, hey, we shouldn't cover MRIs. I know that's crazy. That's crazy talk, right? But okay, fine. That's not politically expedient to go from what we have now to say no MRIs. But the way to do it is to create high deductible plans, healthcare plans, which basically shifts those costs. Do you know what happened to the nurse practitioner? And I wasn't really giving her advice per se, but we just spoke as I was like, well, speaking as a parent because I'm not a pediatric.
You probably did the echo for free.
Yeah, no, right. No, yes, I charged half, and no, I'm kidding. But eventually she didn't end up choosing to get it and choosing to wait and see it, whatever. So. And that was like 4 years ago, and I think the child is still alive.
Isn't like, for example, I think the hospital, because the hospital charges more. I mean, it's all like, they say they already know that United or Cigna they're willing to pay $2,000 for the echo. So it would be silly for them not to get the 2,000, like bad business. If you're a hospital, you should get what you can get.
Yeah, no. So the insurance, that's the problem, Chadi. The problem is we've set up a system where you have created $2,000 MRIs. How do you break the system so you don't have $2,000 MRIs? Because once you don't have $2,000 MRIs, right? Then now things we're in a much better place for everyone. And by the way, MRIs then are way more accessible to everyone, not just people that have an IBX card and it's crazy. We have a system where your healthcare is tied to your employer, which is a nut system, right? Now all of a sudden you can have a system where you don't, when you get seriously ill, you probably lose your job. And now suddenly, so it's this massive stress. We have a healthcare system that doesn't work for us. So I'm talking about moving towards a system that doesn't work. And that system, counterintuitively, I think physicians need to understand this.
Answer me
actually removing
the second part of the question about the cost of drugs with Mark Cuban.
Yeah, so I don't have a problem. I don't have a problem with, so, again, there are two conversations to have, okay? Like, how do you, like, what is the basic problem with PBMs, right? Why do PBMs exist? PBMs exist, pharmacy benefit managers exist because they are basically pooling customers, right? And going to manufacturers and saying, hey, I got 10 million people tied up here, and there's one drug, and then I know there's three drugs and that are reasonably speaking equivalent. If we take your drug and put it on our formulary and direct our 10 million people to get it, okay, there's value to that. So we want a discount, okay? And so look, PBMs are just a natural thing that's going to arise because people are going to try to get together to negotiate lower prices, right? So my problem.
I mean, that was the promise of PBMs. They never did that.
Right. So my problem with going after PBMs and the way that you're going after it, okay, is that you're basically going after people getting together to say, hey, I'm leveraging my size to get a lower price from you. It's like, well, what are we going to do? Are we going to go after trade? Are we going to go after unions next? Are we going to say that unions aren't allowed to negotiate for higher prices?
No. But they never did that. I think that was the promise of the PBMs. The reality is PBMs, they promised that, like you said, I'm going to go to the manufacturer, I'm going to negotiate a lower price for you.
Right.
But they actually never did what they claimed that they were supposed to do.
Well,
to my knowledge,
it gets complicated with PBMs, right? Because of course there's a list price. And then there's a price that's given, and of course, the problem with PBMs is that what they take is a function of the discount that they're able to give, and so it makes most sense for everyone to kind of win in this, and who doesn't win is the patient, which is again why it's a silly system that's never going to work the way it's set up. So the best way to do it is to remove remove again third-party payers for drugs out of it, and then that would be the best thing to do, right? But as it stands, yeah, you have to create all sorts of Byzantine rules because now there's these crazy incentives that PBMs have and manufacturers have, right? In order to get the best price, it's like, okay, if it costs me $10 per pill, I'm going to jack up the price to $1,000 a pill because the number is meaningless. And oh, by the way, I'm going to negotiate the price down to this number, and the PBM's happy because hey, I got you down 80%, but it's
Right.
insane. You just jacked it up 1,000%, got it down 80%, and you take some and so who's not winning? The person that's not winning is the payer. The payer's not winning, right? But guess what, Chadi? That's what I'm saying. That's what I'm saying. And then our solutions, this is why I wrote the thing, the little tweet that said that, look, our solution can't be to violate the fundamental tenets of what makes like America America. I mean, you can't like then say, okay, I'm not going to allow PBMs to do this, and you have to make all your things completely transparent. It's like, am I supposed to make all my business dealings completely transparent? Like, do you need to know? Does everyone in America need to know exactly what Coca Cardiology's profit margins are? Is that how
Would
we should?
like to, would definitely would like to. I
So
expect you,
my
I
point is,
expect your balance sheet to be forwarded to me immediately.
so this whole idea of like, they're so greedy and we must go after greed. It's like, okay, how do we, this is not how America works. America
No, no,
works
I
by,
get it. I think
by,
you want to
by
maintain the capitalism.
capitalizing.
Yeah. Hmm.
Yeah, you capitalize on individuals' greed to create a system, to create something that everyone is running around trying to do the best for themselves, and because they're trying to do the best for themselves, you get a system where you have Intel chips that are
But the
cheaper than.
issue with PBMs, though, Anish, the issue
Yeah.
with PBMs is they were the fundamental reason the
No,
business
I
existed.
want PBMs to go away. I want PBMs to go away.
Okay, I want to make sure
I don't have
you're
any issue.
okay.
I have no issue with PBMs going away. I think
Okay.
the way to get PBMs to go away, all right, is to take out third-party payment as much as you can from this, right? I don't think, for instance, that we need PBMs for insulin. Do we need PBMs for insulin?
I don't think
Why?
so.
Do you know what happened? The market, and again, this is before Joe Biden's $35. I don't know exactly what he did, but there's some insulin cap or whatnot.
Hmm.
Right? Before that, you could go to Walmart and get 1,000 units of insulin, or basically a month's supply of insulin, for $30. Okay, I take care of a tremendous number of patients who are underinsured, don't have insurance. Run diabetes clinics for that group of patients because they don't have insurance, and they're my cardiology patients, and they don't have anywhere to go to, right? And I can tell you that the barrier to take care of these patients is not that they're unable to pay the money to get the insulin. There's all these different social determinants of health,
Sure.
barriers for them doing that, right? And that have nothing to do with their ability to pay for X, Y, and Z drug. And the market, by the way, provides for that. Many times it's cheaper for people not to use their insurance card, right? And just pay cash for a statin, right? It's because and so the reason is you have all these different players in the space, pharmacies, right? Pharmacies want an insurance program because they partly make more money that way, right? I
So
think so. Look, so Mark Cuban, I think, has done a good thing in the current system, but it's one of those things where you have a billionaire getting into the space. Mark Cuban is making a nice amount of money. He is doing things that are better than what a PBM is doing by having
right.
transparent
Yeah.
prices, by only doing a 15% markup. So Mark Cuban is actually doing good things in this space. I don't have a problem with what Mark Cuban is doing in
So
terms of.
to just to be efficient, because we're going to be running out of time. There
Yeah,
are two issues I want to talk about. I want to get your reaction to, and then
yeah,
I'll let you go because we're taping this Sunday night, very late. It's clearly
yeah.
both of us have no lives, which is great. I want to react to the Inflation Reduction Act. Your thoughts on the Inflation Reduction Act, which is again suggesting the government can negotiate prices for the top 10 drugs, blah, 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 start 2026. And then, again, they already released the top 10 drugs as an example, and this will change with time. And as we know, pharma is lobbying a lot against the Inflation Reduction Act. So your thoughts, is this a good thing, bad thing, Inflation Reduction Act?
No,
And
I
then
think
and then
I
the
think it's
340B, and then I'll let you go.
No, I don't think it's a, I think principally it's a bad thing. I think we have to hew to certain principles, and I think principally speaking, you cannot negotiate with the government. The government is like the biggest mafia around,
Why? Why?
and
Why not negotiate drug prices to make it more affordable?
no, but I mean, the government can't, the government just tells you what to do, right? It's like, I mean, can I negotiate my Medicare rates with the government? I
No,
mean,
no,
I
no.
don't think you can affect,
But the Inflation Reduction Act is saying we're looking at the top 10 drugs, for example. They release the top 10 drugs that they are going to negotiate for. We're going to go to the manufacturer and we're going to try to bring down the prices because we need to get set of data to see how much, for example, money was spent on R&D, things like that. I think that the point of the Inflation Reduction Act is that some of these drugs that are making, billions and billions of dollars in profit a year is just so
yeah.
expensive, and we need to negotiate their prices down. We'll still make sure that pharma makes money, the company manufacturer makes money, but at least limit the amount of profit to make it more affordable.
Yeah,
That's
I
what
think
happens in Europe. I mean, in Europe, they negotiate.
right. I think we do this over and over again, and I think as soon as you have the government trying to negotiate these things, trying to set prices, I think it's the government look, the government spends $7 billion and created like 10 electric vehicle charging stations. Elon Musk spends $1 billion and not only does he have electric charging vehicles that are, 1,000 of them or something, he's also sending people to space at 1/10 the cost of NASA. Look, I think the government is not very good at very many things, and you really need to limit what they do. Yes, will it work in the short term as a band-aid for whatever? Maybe. Long term, will it
So you're
be
skeptical,
yeah, no,
and I think that's fair. I think
I'm
that's
absolutely
fair.
skeptical. What is the point? What is the reason to cap? I mean, they wanted to cap, insulin prices at $35 a month, right? You already had insulin at $35 a month, right? So I don't see what the point of this is. And then once you have legislation that exists over time, it gets perverted so that those funds that are going in will get squirreled away to somewhere or
See,
the other. So
for the Inflation Reduction Act, I'm a little
yeah,
bit more open-minded than you are. I think it's tough to know the impact of this. I'll have to see. It's going to become, it's right now they're in negotiations between pharma and between CMS and the manufacturers of some of the 10 drugs that were released to negotiate with. And we'll have to see what they actually agree on in terms of prices. And then it's tough. I mean, again, our drugs in oncology, the prices are really, really astronomical. I mean, I mean, it doesn't even, it's like stratosphere land. And so I can, and some of these, biologics, right? Like the Humira and all of these things. So I can understand. I'm with you. You want to try to minimize government interference in free markets as much as possible. The
yeah.
problem is that I feel like it's gotten out of control.
No, but it's gone because it's a
Yeah, I
threat.
hear you. I hear
The
you.
threat is that the cost is so high, so therefore we have to have insurance. And
Yeah.
this is where the pharma companies are not good, are terrible because I mean, not terrible. They are rational actors that are trying to maximize their own profit, just like physicians are. And I think what pharma wants is a blank check from third party payers. And pharma does not want to negotiate with you and me in our living room because we are not going to be writing some massive checks,
No,
right?
we're not. No,
Um,
definitely
so
not.
so
My,
pharma is not interested in that, right? And the people just don't want to think about it. But what we need people and physicians to understand is that the best way to get the most drugs at the lowest cost actually is to open it up and to take
yeah.
away this third party payment system, right? And once you take that away, and then you can have and again minimize the imprint. I'm not saying take it away completely. So you're always gonna have
Yeah.
some amount of private insurance, and you may even have government programs to cover the truly indigent that are below something. You can have
My
that
my
as a
my
stopgap.
my
But
last question.
yes,
How do we get rid of 340B? Do you want to get rid of it?
yeah, absolutely.
How
And
do we
again,
get rid
this
of
this
it?
is this is a perfect example of like, I'm sure that some version of you and me discussing this when the 340B program came out, but like, hey man, this sounds great. We have low income patients that can't get access, and the government, I mean, again, this is the whole government negotiation thing. The government generally doesn't negotiate. They just dictate. You cannot negotiate with the government in general. They may pretend they're negotiating, but you're not actually negotiating, right? So the government forces manufacturers to sell hospitals drugs at a much lower cost, right? And then that hospital now has access to these drugs, and now is supposedly 340B programs that are supposed to be targeted towards the indigent, but of course the percentage of that drug that's given to the folks that it was intended for is some small percentage, right? And meanwhile, the hospitals are basically printing money because they are, through government mandate, are getting drugs at a very, very low cost and using it for a bunch of people and they're getting significantly higher costs for higher amounts for in terms of reimbursement. So this is exactly why the 340B program is exactly why.
But the hospitals abused it.
Yes, but that's always going to happen.
It's not the government's fault.
Yeah, well, no, well, again, what happens is you have government passes legislation, right? And one way or the other, our taxpayer dollars goes and subsidizes and ends up in the pockets of some large players, and then we complain about wealth inequality, and then we complain about, then we try to come up with some other band-aid rule that'll do it. Instead, what we should do is just eliminate the 340B program completely.
I agree with you. I just don't think it's going to happen. But look,
same thing with the Inflation Reduction Act. So, I mean, 10 years from now, we'll be talking about, oh my God, look what happened to the IRA Act. Because I guarantee you, the moment you have these programs, it is a way to make a small, narrow band of people rich. So, to the four leftists that listen to this podcast,
hey, my podcast is apolitical. First of all, I have listeners from all political parties.
No,
I don't talk politics. This is a policy podcast. I don't really care what you're voting for.
No, I'm sure they normally listen a lot, but I'm saying they may get scared away by Koka being on the podcast. but for the ones that are still listening, what folks have to try to understand is that all of this is to decrease this wealth inequity that happens, because every time the government comes up with some program, Medicare, right? Medicare, doctors and healthcare providers, from hospitals, etc. That Medicare was like a cash cow, right? And it just increased systemic inequalities. All right. The same thing happens for every one of these little programs that happen. You just overall make all the things that, again, I original OG leftist here. You make all those things that I cared about much, much, much worse. So it's counterintuitive to think about that. But if you move towards and you hew towards principles that involve not having these third-party payment mechanisms, you will actually end up in a place where you have more access to healthcare, physicians, providers, drugs. You have more access to all of those at a cheaper cost, and that's what we want. And by the way, we haven't even touched on the fact that we are $33 trillion or something like that in debt at this point, right? Medicare spending is $900 billion, right? Medicaid spending is $734 billion, all right? Social Security spending is $848 billion. And by the way, the military, which everyone wants to cut, that's $900 billion. So what you have when you're talking about Social Security, Medicare, and Medicaid, you're talking about $2.1 trillion worth of spending, right? And we have a country that's $33 trillion in debt. So yes, I realize the most important thing to many physicians, is getting rid of prior auth, but we really have to approach these things with some context and understand, that if we just sit there and complain about this stuff, the rest of the world, the rest of the United States, the taxpayers, look at us like, we're children in a sandbox throwing tantrums, right? And it's like, do you not understand what's going on? So physicians really, really need to get, when we're talking about these things, especially when we're publicly talking about these things, have a better understanding of context and multiple different, the context of what we're making these arguments.
Dr. Anish Koka on Healthcare Unfiltered, thank you so much for coming and visiting with us.
Thank you, Shadi. Thanks so much for having me on.